A very good morning to all of you. I and my critical care team from AIIMS Bhubaneswar thank you for the opportunity of presenting in front of you what have been our agonies and ecstasies over the past 4 years in setting up the critical care services in Bhubaneswar, Odisha, one of the more underdeveloped parts of India. AIIMS Bhubaneswar, a 1,000-bedded hospital, was set up about 4 years ago by the government, aiming to correct the regional imbalances prevalent in the availability of reliable and affordable tertiary healthcare services and medical education in this part of the country. We are situated here on the eastern coast of India, and this is perhaps one of the poorest parts of the nation. More than 80% of our population depend completely upon public health services for all their health needs. When we began handpicked faculty for this institute, we started with the knowledge that we had a good infrastructure. We had ventilators, monitors, laboratory support. These were present. However, trained manpower and a general ignorance about emergency and critical care services was a big concern for us. Another issue was the humongous patient loads faced by us. The video here shows a normal day. The queues are sometimes more than a kilometers long, and patients start queuing up before 4 a.m. in the morning. This is quite a common sight at our hospitals. Because none of us were trained here, it also took us some time to get used to the unique socio-economic milieu and spectrum of diseases that are prevalent here. Dengue, Japanese encephalitis, scrub typhus, TB meningitis, and malaria are extremely common. Having taken stock of what we were starting with, we wanted to improve our services. We trained our students and senior faculty in basic life support and advanced life services. Then we moved on to liaising with the state government, the medical personnel present in the peripheral health services, the ambulance personnel, and the police, who are frequently the first responders for road traffic accidents in this part of the country. We designed trauma and critical care manuals for our roads and hospitals. The aim was to form a team so that with better communication and primary care, the patient, when he reached to us, would be still salvageable. We realized that there was a lack of good critical care training. So, with the help of the Indian Society of Critical Care Medicine and the basic team, the basic for nurses on the wards, we set up a series of trainings for our doctors and our nurses. We also began a structured critical care fellowship program. Presently, 3 of our students now manage private ICUs in the city. We started looking at our own critical care services. Our 17-bedded ICU with 11 level 3 and 6 level 2 beds, with a manpower of 1 nurse for every 2 to 3 beds, some residents and later on a trainee, was far from what we thought was ideal. It was being run chaotically on a first come, first served basis. There was a lack of basic triage policies. We were delivering expensive care in conditions which were futile for unsalvageable patients, sometimes for months at a time. We wanted to make a new way. The goal was to demonstrate improvement without making any demands on an administration for whom critical care services were not the primary concern at that point of time. We had only basic weapons in our armamentarium, and those we used. Simple steps of reaching out to different departments, of empowering, involving, and engaging nurses and trainees, and putting in place key performance indicators. All stakeholders were roped in into our efforts. Unsurprisingly, as we continued diligently with these strategies, we realized that inherently people wanted to start accepting change. Initiating ICU bundles, assessing nutrition, and implementing protocols for feeding and for sugar control, for safe patient transport, and policies for infection control were started. Along with regular bedside classes, we had mortality and morbidity meetings, and soon we were able to demonstrate to our administration the significant improvements we were making in resource utilization and in patient outcomes. For example, before our interventions, more than 56% of patients in our ICU had Apache scores of less than 7, patients who could be well managed in the wards. Afterwards, we could bring this down to less than 36%. In our institute, pipeline oxygen is only available in the critical care areas and in the emergency areas. We saw that we were harboring 70% of patients in the ICUs who did not even need oxygen. This, after our interventions, was reduced by more than half over 3 months. 78% of our patients were only being observed in our ICU for hypothetical deterioration. We cajoled, we spoke, we convinced, and we could reduce this number to 36%. These changes were duly recognized by our administration. This improvement in resource utilization has not only sustained itself but has also steadily improved over time. We are taking in sicker patients and contributing more to their care. The critical care team, which as a concept, or the Department of Critical Care, which does not exist in many government institutes in India, was formally recognized and is now involved in policy making at our center. Hospital acquired infections plague ICUs the world over. But with a young and enthusiastic microbiology team and strong support from the administration, our infection control practices are improving every day.
That has been the journey, somewhat, so far, and yet there is a long way to go to still understand the emotions and attachments of our peoples, wherein it is not just a sick person in the ICU, but also his entire family, which is losing their day's earnings and wages by being with their relatives. Our plan for the future is not only to look at what critical care research and services is being done in the developed world, which they are good at, but also to look at what is important to us. We are focusing on geriatric critical care, on nutrition, and rehabilitating the chronic critically ill. Because this concept, which is necessary, is virtually non-existent in our healthcare system. We are looking at palliation in critical care and at patient outcomes. We are looking at involving the family in critical care of their patients.
We run a program for actively involving patients' families in caring for them. This has enabled us to rehabilitate them back into their houses and to the society. The patient care has usually been impeccable in families who are convinced. Hospital acquired infections have decreased, resources have been utilized better for the more deserving patients, and family members have been able to return back to work.
Here, we see our nurses explaining to Lakshmi's daughter about caring for a tracheostomy and changing the tubes. With a mobile first population and dirt cheap data, we are able to keep in touch with them over phone and WhatsApp for troubleshooting. We have seen that sincere training and backup support goes a long way, and
And their relatives then become convinced that it is possible to take patients back home with tracheostomy tubes, suction catheters, nasogastric tubes, and oxygen concentrators, get them better, and get back to their lives. They become our champions, and this lot of the first of our patients and their relatives now counsel the next lot of relatives to go back home. Here is our team of young doctors, nurses, and students who are all passionate, not only in curative but also rehabilitative critical care. These here are patients from another project of ours where we have a clinical psychologist who is engaged in this project who goes home to all of these patients who have been discharged from the ICU and follows them up for post intensive care psychiatric morbidity. We have followed up a 550 patients who were screened. 350 of them have been followed for more than 6 months. They have now become our friends. This part of the study has been submitted to SGANZICS. As a part of taking care of the families as well as the patients, we have also now started maintaining ICU diaries or Indianized versions of the same, a concept which has been implemented in Europe and America before this, we find is going a long way in not only convincing and transforming our patients to have more faith in the healthcare system, but is also decreasing their post ICU morbidities, psychiatric illnesses, and improving outcomes.
So, over the last 4 years, we have had our modest attempts at getting to know our own data, at intervening in areas that we think are presently very important for our critical care services, looking at the critically elderly ill, the nutrition, the quality of life of our ICU patients, and our nurses and their attitude towards palliation and end of life care issues have been our points of focus.
we have big dreams for critical care. A developing economy considers preventive medicine to be much more important for its population and healthcare policies than any acute medicine. However, we dream that with collaborating with the right people, better teams, better hospitals, people who have had these struggles before us and have overcome them, we will also be able to break the shackles and bring critical care to a position that it deserves to be in.
With that, I bring you greetings from Odisha and AIIMS Bhubaneswar, and thank you again for giving me this opportunity. Thank you.